Good afternoon, everybody. So Happy New Year. Welcome back to a new year, 2023. And I think it's a great way to start the year with our lecture series. So this is going to be the first named lecture series that SERI has basically done, and it's really to honor people who've made a big achievement and dedication in SERI's history. So our first lecture in the series is going to be Professor Chu Seok-jin lecture. Now, as many of you know, he was a pioneer, really started up SERI in 1997 and really had the thought process of starting research in myopia. And it's my great pleasure to somebody who has really expanded the field of pathological myopia over that time period. And to honor her today, we have Professor Kyoko from Japan, and she's going to be the inaugural Chu Seok-jin SERI lecture. So welcome, Professor Kyoko. Thank you.
Thank you. Thank you very much for inviting me today, and thank you very much for your kind introduction of me, Jod. I'd like to thank you all for this great honor to speak for Professor Chu Seok-jin lecture today. Thank you very much. And this is my financial disclosures. And as you all know, the prevalence of myopia has been increasing worldwide, especially in East Asia. If the current trend continues, by 2050, half of the entire population in the world will become myopic, and 10% of the world population will become highly myopic. And most of myopic patients maintain good corrected vision. However, pathologic myopia is an exception. It's a major cause of blindness. For example, it's the leading cause of blindness in the Tajimi study in Japan, and the second most common cause of low vision and blindness in the Beijing Eye study in China, and the second most common cause of visual impairment in the Shanghai Eye study in Taipei. And then, what causes the blindness in pathologic myopia? Actually, there are three major causes: myopic maculopathy, especially neovascularization, and myopic traction maculopathy, and glaucoma or optic neuropathy. And the cause of developing above complications is eye deformity, especially characterized by posterior staphyloma. Today, I will focus on posterior staphyloma because it's a critical lesion to differentiate pathologic myopia from physiologic myopia. Posterior staphyloma is an outpouching of the wall of the eye and is a hallmark lesion of pathologic myopia. In this Optos image, we can detect staphyloma edges in eyes with such deep staphyloma with steep edges. And the right image shows a globe with axial length of 37 millimeters. Two staphylomas, one peripapillary and the other around the macula, are seen. Historically, the first description of posterior staphyloma was made by an Italian anatomist named Antonio Scalpa. He described two canavar eyes whose posterior portion of the eye had pronounced outward bulges, but he didn't think about an association between staphyloma and myopia at that time. And in 1977, long after its first discovery, Brian J. Curtin greatly expanded the clinical understanding of staphyloma, and he made these classifications of staphyloma. And surprisingly, he made, without imaging techniques, he made this classification based solely on ophthalmoscopic examination and schematic drawing. And Curtin already emphasized the importance of staphyloma in defining pathologic myopia 40 years ago. Based on his observations, he suggested that it is apparent from the bewildering range of refractions and axial lengths found in this study that these measurements are unreliable indicators of even the very diagnosis of physiologic or pathologic myopia. The morphology of the posterior staphyloma would be a much more reliable basis for genetic studies. But first of all, what is staphyloma? Actually, the clear definition of staphyloma was not made, and there was some confusion in its definition. And in our book of pathologic myopia, Dr. Spade clearly defined that staphyloma is an outpouching of the wall of the eye that has a radius of less than the surrounding curvature of the wall of the eye. So the left one is a normal eye shape. And the middle one is axial myopia. Axial length elongation mainly occurs in the equatorial region, and that does not induce much alteration in the curvature of the posterior part of the eye. So this is an axial myopia, but not staphyloma. But when the second curvature develops, it's a staphyloma. So this is an OCT image, and sometimes a generalized bending of scleral curvature due to axial elongation is confused with staphyloma. But staphyloma is a protrusion of a limited area of the posterior fundus with its edges, and different from generalized bowing. So the detection of staphyloma edges is necessary to diagnose staphyloma. Then how can we objectively detect staphylomas? OCT is useful to examine the scleral curvature, but the scan length of widely used commercially available machine is not long enough to cover the entire extent of wide staphyloma. Wide field fundus imaging might be useful for steep edges, but it doesn't provide 3D information, so mild staphyloma cannot be observed. To solve this, we established 3D MRI of the eye. 3D MRI enables to show the entire shape of the eye in three-dimensional way from any angle. Emmetropic eyes are spherical, but the eyes with pathologic myopia are not simply elongated, but severely deformed. And the pattern of eye deformity is different among patients. And the most common type of the staphyloma is wide macular staphyloma, which was found in 46% of highly myopic eyes. In Optus image, the border of staphyloma is seen as pigmented or depigmented lines. 3D MR images viewed from nasally, from inferiorly, and from back show a protrusion of wide area of the posterior segment. And the upper and temporal border usually are steeper than the other edges, so we can see notches along these edges. The most protruded point existed along the central axis in half of the cases, but lower to the central axis in the other half. So the inferior part of the eye tends to expand more than the upper part for unknown reasons. But overall, wide staphyloma is deep and narrow staphyloma is shallow. And the narrow macular staphyloma was found in 11%. And in the eyes with narrow macular staphyloma, 3D MRI shows a so-called cylinder shape like a strawberry. Protruded area is narrow in the images viewed from nasally and from inferiorly and from the back. And the protrusion of the posterior segment seems to be pointed as a triangle, which is different from broad and blunt protrusion in eyes with wide staphyloma. The most protruded point exists along the central axis in all cases. So 3D MRI is a powerful tool to delineate the shape of the entire eye, but it's still not feasible as a screening purposes. So we now use ultra-wide field OCT, which was a prototype by Canon with scans 23 millimeters wide and 5 millimeters deep. This 5 millimeter depth is important to include large up and downs of sclera. And currently it's commercially available in Japan and in Europe. I show some representative cases with staphyloma. In the Optus image, the upper edge of staphyloma is observed. 3D MRI image viewed from the inferior and from the nasal side show a wide macular staphyloma. In B-scan with wide field OCT, the staphylomatous region shows a posterior displacement of sclera. And at this point, scleral curvature changes, and this area is staphyloma. And staphyloma edges show consistent features, which are gradual thinning of the choroid from the periphery toward the staphyloma edge, and gradual rethickening of the choroid toward the posterior pole. And by detecting such of the OCT features, we can objectively identify staphyloma edges. And 3D OCT movie clearly visualizes the entire shape of staphyloma. And different from 3D MRI, spatial relationship between staphyloma and the optic disc, macula, and retinal vessels is clearly visible. This facilitates the understanding how visually important nerve tissues are damaged by eye deformity in pathologic myopia. In the second case, in a horizontal scan by wide field OCT, the staphylomatous region shows a posterior displacement of the sclera, and this is an staphyloma edge. And staphyloma edge shows consistent features with the previous case. And in 3D OCT movie, you can see the entire shape of staphyloma. Staphyloma is usually horizontally wide. And the spatial relationship between staphyloma and optic disc, macula, and retinal vessels is clear. And the third patient has inferior staphyloma. In Optus image and autofluorescent image, upper edge of inferior staphyloma shows depigmentation, and choroidal folds spreading from the staphyloma edge are seen. In a vertical scan with wide field OCT, such deep staphyloma can be seen to the entire extent. And this is 3D OCT movie. It clearly visualizes the entire shape of inferior staphyloma and even chorioretinal folds emanating from the staphyloma edge because of its high resolution. And we then compared the detectability of staphylomas between wide field OCT and 3D MRI. And the results showed that kappa was 0.609, and the strength of agreement was considered to be good. And this suggested that wide field OCT can replace 3D MRI for accurate detection of staphylomas. And different from 3D MRI, wide field OCT visualizes a spatial relationship between staphylomas and myopic fundus lesions. And a good example is myopic retinoschisis. In this patient, this is staphyloma edge. As you can see, inner and outer retinoschisis is restricted to the staphylomatous areas, and they do not go beyond the staphyloma edge. And in this patient as well, these are staphyloma edges. And like the previous case, outer retinoschisis is restricted within the staphylomatous areas. But in contrast, in the eyes without evident staphyloma, diffuse retinoschisis is seen. In this patient, sclera is generalized, bowing generalized in general, but choroidal thickness is uniform, and no OCT features suggesting staphyloma edges. And outer retinoschisis is seen only in the macula, but inner retinoschisis is widespread toward the periphery. And in the vertical scan, widespread inner retinoschisis is well observed, and within the space of inner retinoschisis, actually sporadically remaining retinal vessels are observed to be actually floating without surrounding retinal tissues. So this shows how strong retinal vessels, or vessels in general, are. And in this 3D movie, you can see detached inner limiting membrane, and under that, you can see a lifted retinal vessels like a grasshopper legs. And you can see many columnar structures between inner limiting membrane and retinal vessels. So we can see a view which cannot be observed with our own eyes prior to surgery. So it provides important and useful information before surgery. And interestingly, staphylomas can occur in non-highly myopic eyes as well. And Nankai Wan from Taiwan reported the clinical characteristics of posterior staphylomas in myopic eyes with axial length shorter than 26.5 millimeters. Their figures showed that the eyes showed prominent protrusion and eye deformity without a large increase of axial length. And supporting their study, staphylomas are also found in non-myopic fellow eyes of patients with unilateral high myopia. By using 3D MRI, we have found that staphyloma was detected in 40% of non-highly myopic fellow eyes. In this patient, axial length is 24 millimeters in the right eye, which is normal, and 28 millimeters in the left. 3D MR image of the left eye shows a posterior outpouching with depression along the upper edge of presumed staphyloma, but her other eye has a 24 millimeter axial length. And wide field view, we still see staphyloma edges. And 3D MRI of this emmetropic eye show similar shape of staphyloma, just like her other eye. And this suggests that unilateral high myopia might not be a unilateral abnormality. It's a bilateral eye deformity, but the difference between the two eyes is the degree of staphylomas. So emmetropic eyes become myopic by axial elongation. And this axial elongation mainly occurs in the equator of the eye. And when I joined the high myopia clinic long time ago, I thought that the staphyloma formation was just a continuum of axial elongation, even though the affected area was different, posterior pole, which was different from an elongation of the equator of the eye. However, in 3D MR images of the eyes with deep staphyloma, the eye wall outside the staphyloma often flattens, sometimes flattens more than normal eyes. And this is our New Year favorite, the rice cake. When it is baked, it uniformly swells at first. But once the central part pops out, the surrounding part becomes flattened. So the similar thing might happen to staphyloma development. So staphyloma formation is a drastic change of the eye shape and is an independent phenomenon from axial elongation. And although staphyloma is really important for pathologic myopia, it's not certain at around what age staphyloma starts to develop. With wide field OCT, we can now examine highly myopic children to solve this question. Results show that staphylomas developed at a much younger age than previously thought. For example, this is an 8-year-old girl with axial length of 26 millimeters. At baseline, the inner scleral curvature is inclined toward the optic nerve, and no staphyloma edge is seen. 3 years later, the axial length has increased by 1 millimeter. Scleral inward protrusion, suggesting a staphyloma edge, is formed nasal to the optic disc. And the scleral curvature itself has greatly changed. The macular sclera bows more posteriorly, and the fovea is symmetrically located at the most protruded point of the sclera. So even in 3 years, by an increase of 1 millimeter axial length, scleral curvature has changed a lot with a new formation of staphyloma edge. And the location of staphyloma edge also changes with time. In this 11-year-old girl, staphyloma edge already is seen nasal to the optic disc at baseline. And 4 years later, the axial length increased only by 0.6 millimeters. A nasal staphyloma edge has become farther away from the optic nerve, and in parallel, the posterior bowing of the sclera around the macular area has increased, accompanying with scleral curvature from symmetrical around the fovea to asymmetrical around the fovea, with its deepest point shifted temporal to the fovea. And this is an 11-year-old girl. Mild staphyloma edge is already seen at baseline, and interestingly, many staphyloma edges in children occur around the optic nerve. And 4 years later, the axial length increased only by 0.2 millimeters. But in addition to pre-existing edge, a new edge is formed temporal to the optic disc. In parallel, the sclera is bowed more posteriorly, with its deepest point temporal to the fovea. These data show that staphylomas might develop at a much younger age than we previously thought. And children who become pathologic myopia eventually may already be different from usual myopes already at their childhood. So early detection of staphylomas and early interventions to prevent the staphyloma formation is important for preventing blindness in the future. And the main role of sclera is to protect the central nervous tissue from mechanical insult. And both sclera and the skull bone contain nervous tissue in them. However, compared to a hard skull bone, the sclera is a fibrous tissue and more fragile. And it's easily imagined that the deformity of the sclera can mechanically damage the central nervous tissue inside. And we believe that the integral feature of pathologic myopia lies in the eye deformity, and pathologic myopia is a representative disorder developing eye deformity in an acquired fashion. At our myopia center, we see many patients like this. And every time I see such patients, I feel devastated because I can do nothing to save them. So before becoming too late, we need to detect staphyloma at its early stages with wide field OCT, and it's necessary to establish therapies targeting staphylomas. Future therapies targeting staphylomas have been investigated, including scleral collagen cross-linking and scleral regeneration. Further studies on how and where staphyloma begins may provide more insights for the treatments targeting staphylomas at an early stage before vision-threatening complications occur. In the remaining time, I would like to talk about the optic nerve damage in patients with pathologic myopia. Because pathologic myopia develops many different kind of pathologies, including cataract and glaucoma. And actually, glaucoma is a huge issue. Almost half of our patients lose sight because of glaucoma, and they develop earlier than usual glaucoma. They lose sight in their productive ages. So, for example, this is a 61-year-old woman. Her visual acuity was 0.02. The diagnosis at referral was macular atrophy caused by macular neovascularization. The diagnosis was correct, but her bigger problem was the optic nerve damage. She had only a tiny visual field in the lower fundus. When she came to our clinic, she was unable to walk to me. And her retinal lesions were restricted to the posterior fundus. So her visual field results were mainly considered to be due to the optic nerve damage. And usually the IOP is low. And however, despite the low IOP, these patients continued to lose sight with time. And this is a 30-year-old man. And he was referred to our hospital because of vision loss. And the diagnosis at referral was again myopic maculopathy. But when he came to us, he was also even unable to walk into the examination room by himself. His visual field was already like this. And like most patients with pathologic myopia, the IOP is low. And the optic nerve damage develops in severely myopic patients much earlier than non-myopic glaucoma patients, and it's not rare for them to lose sight completely when they are young. And difficulties diagnosing optic nerve damage in pathologic myopia include this. And the presence of optic nerve damage is underdiagnosed and overlooked, and which is a huge issue. This is because optic disc is tilted and deformed, and so difficult to identify glaucomatous optic nerve damage on fundus. And because of large PPA, OCT measurement in peripapillary area is less reliable. And Humphrey visual field is difficult to interpret because of coexisting myopic maculopathy as well as large PPA. So it's useless. And so at our myopia center, we perform Goldman perimetry and to see whether they have peripheral visual field loss for all patients at least yearly. It takes a lot of effort, but we just do it. And many pathologies occur in papillary and peripapillary areas of pathologic myopia. And I think what happens in the optic nerve in pathologic myopia is an extreme of what happens in glaucoma, usual glaucoma. Of course, there are some lesions which only occurs in pathologic myopia. One example is the optic disc pit, which is known as laminar cribrosa defect. But laminar cribrosa defects in pathologic myopia tends to be large and deep. And this patient has acquired megalodisc due to pathologic myopia. And ANFAS image shows multiple laminar cribrosa defects at the upper pole and along the temporal margin of the optic disc. And OCT image show a wide and deep pit, and the depth is beyond 1 millimeter. And because of this pit, the laminar cribrosa is torn and maybe does not function well as an absorber of the intraocular pressure. And in this is another patient. In this image, a large laminar cribrosa defect is seen here, which is huge. And you can also see projections of torn laminar cribrosa here. So extreme finding is seen in pathologic myopia. And conus pits, this is specific to pathologic myopia and specific to eyes with large PPA. And in ANFAS image, you can see multiple pits. And in OCT image, sclera is disrupted here, and over the pits, the retina is lost. So we recently analyzed structural abnormalities in the papillary and peripapillary areas and corresponding visual field defects in eyes with pathologic myopia. And one of the difficulties analyzing a relationship between structural and functional abnormalities in pathologic myopia is that many pathologies coexist in the same eye. For example, in the top case, there is laminar cribrosa defect here, and there is a scleral ridge here, and there is no retina on the slope of the ridge, and her visual field is like this. And in the second case, laminar cribrosa defect, and this is a scleral ridge, and there is almost no retina here. And in this case, this is a conus pit. So many different kinds of pathologies occur in the same eye. So this complicates the diagnosis. But we analyze that, and these kinds of different abnormalities are seen: narrow defect, laminar defect, and wide defect, and ridge formation, and ridge and conus pit, and ridge and laminar, so many different combinations. But we have, through this structural and functional relationship, we have found that in the end, regardless the laminar cribrosa defect or structural abnormalities, the retina overlying the abnormalities are important for visual field defects. So in this patient has a wide laminar cribrosa defect, but the overlying retina maintains its thickness, and visual field has no defect. And in this patient, this eye has a large laminar defect, and overlying retina thins a little bit. And this patient has a paracentral scotoma. And also retinal thinning is seen on the slope of the scleral ridge. And in the last patient, there is a large defect. And also the overlying retina is lost and a big central scotoma is seen. So laminar cribrosa defects are seen in many patients with pathologic myopia, but the presence of laminar cribrosa defect alone does not impair the visual field. The status of the overlying retina is problem. And when the laminar cribrosa defect occurs in a later time, for unknown reasons, overlying retina is sucked towards the laminar defects, and then defect of retina seems to occur. But then, why the retina overlying the laminar cribrosa is going to be sucked toward the laminar defects and get thinner? And for this question, intrachoroidal cavitation or ICC may provide some clues. ICC is usually observed lower to the optic disc, and OCT shows choroidal thickening, and sometimes cystoid space formation within the ICC. And as shown in these slides, ICC itself does not impair the vision, but with time, the overlying retina is also sucked toward the ICC. In this patient, the overlying retina is sucked toward the ICC, and eventually the overlying retina is disrupted, and then visual field defect occurs. Such sucking and herniation of overlying retina may be a common phenomenon for laminar cribrosa defects, disc pits, conus pits, and ICC. And in this patient, there is a conus pit here. And the retinal veins is sucked into this pit and strangely bent here. OCT image shows that there is a conus pit here, and you can see the lumen of retinal vessels here. And the retinal vein is sucked into the pit together with surrounding retina. This suggests that probably due to the pressure difference, once defects develop in papillary or peripapillary structures, overlying retina is sucked into the defects, and finally the sucked retina is disrupted, resulting in visual field defects. There are other factors for optic nerve visual field defects as well. In pathologic myopic eyes, we can clearly see the dilated subarachnoid space around the optic nerve in OCT images. In some patients, at the laminar cribrosa defect, the distance between intraocular space and subarachnoid space is very short. In this case, we see laminar cribrosa defect here, and the distance between these two spaces is 120 micrometers. In such case, I assume that laminar cribrosa may not function too well to resist the IOP. And in this patient, there are two conus pits within the large PPA. And through these conus pits, OCT show a direct communication between the intraocular space and subarachnoid space. In such cases, pressure difference between these two spaces is considered zero, which may be a good thing for the optic nerve, but neither laminar or peripapillary sclera function to resist the IOP. This suggests that many pathologies are going simultaneously going on in severely myopic eyes, and this needs further studies. So, in summary, posterior staphyloma is an important feature to differentiate pathologic myopia from physiologic myopia. 3D MRI and ultra-wide field OCT are useful to detect the entire extent of staphylomas. Staphyloma formation and axial length elongation are separate phenomena, and staphylomas develop at a much younger age than thought, often in childhood or adolescence, and therapies targeting staphylomas before developing blinding complications are truly expected to save eyesight. And due to severe mechanical load, various kinds of structural abnormalities occur in papillary and peripapillary lesions, and these lesions often coexist, which may complicate their influence on visual field. The optic nerve damage can occur and progress at a younger age, and it's not rare to completely lose sight when they are young. Early detection and intervention are truly needed. And this is my last slide. I'd like to thank all members at the Advanced Center for Advanced Clinical Center for Myopia. Thank you very much for your attention.